Hi everyone, and welcome back to the channel. Today we're diving into something you've probably seen before if you've ever been to a clinic or hospital, the ECG, or electrocardiogram. You might remember those sticky patches and wires they attach to your chest, arms, and legs. Those are the ECG leads. But have you ever wondered what they actually do, or why they're placed in those specific spots? In this video, we're going to take a closer look at ECG leads, what they are, how they work, and why they're essential for monitoring your heart's electrical activity. As I mentioned in the previous video, the heart isn't just a simple pump. Every heartbeat is triggered by a series of electrical signals that are generated within the heart. These signals cause the heart muscles to contract and push blood through the body. Now, those ECG leads attached to your body act like tiny hidden cameras. Each one is capturing the heart's electrical activity from a different angle. They send this electrical data to the ECG machine, which then transforms it into a set of waveforms, like a visual representation of your heartbeat, so we can read and interpret what's going on inside. Just like cameras can have different lenses and angles, ECG leads also come in different types. Basically, these leads are divided into two main groups: precordial leads and limb leads. Precordial leads start from V1 and go up to V6, and they are placed directly on the chest. These leads basically look at the heart from the front and give us a cross-sectional view of the heart. But here's the main question: exactly where are these leads placed on the chest? Let's make sure we learn these positions clearly and visually once and for all. First, we need to find the ribs and identify the spaces between them. These are called intercostal spaces. Our goal is to locate the fourth intercostal space. Once we find it, V1 is placed in the fourth intercostal space, just to the right side of the sternum. V2 goes directly opposite in the fourth intercostal space on the left side of the sternum. So far, so good. Now let's move on to the rest. Leads V4, V5, and V6 are placed one rib space lower in the fifth intercostal space. V4 is placed just under the nipple, along the mid-clavicular line. That's an imaginary line that runs straight down from the middle of the clavicle. V5 goes a little more to the side, on the anterior axillary line. V6 is placed a bit further back on the mid-axillary line, roughly in the middle of the armpit. Now you might wonder, what about V3? Well, V3 is actually very simple. It's placed exactly halfway between V2 and V4. So it's right in the middle of those two leads. Nothing complicated, nothing hard. Now let's talk about the limb leads. Why are they called limb leads? Because the electrodes used to record them are placed on the limbs, specifically the right arm, and left leg. These leads look at the heart from a vertical or frontal perspective. Limb leads are divided into two groups. First, the standard limb leads, which are lead 1, lead 2, and lead 3. And second, the augmented limb leads, which include AVR, AVL, and AVF. Each one reflects the electrical potential from a specific limb. AVR shows the right arm, AVL shows the left arm, and AVF shows the left leg. Now the question is, what's the difference between these two types of limb leads? To answer this question, let's first understand how ECG leads actually work. Take a look at this simplified diagram of a single muscle fiber. At rest, the inside of the cell is negatively charged and the outside is positive. This means the entire fiber is polarized. Now, imagine placing two electrodes near the two ends of this fiber. As long as the whole fiber is at rest and fully polarized, there's no difference in charge between the two ends. So the ECG machine shows a flat line, zero potential difference. But suddenly something happens. The fiber starts to depolarize. Positive ions begin to enter the cell at one end. Now, this area becomes less negative compared to the rest of the fiber. This creates an electrical imbalance, and now the ECG picks up a difference in potential between the two electrodes. This is shown on the ECG as a wave or deflection. As depolarization continues and spreads along the fiber, the difference in potential starts to decrease again, and eventually it returns to zero. This is when the whole fiber is depolarized. Then comes repolarization, where the cell prepares to rest again. Positive ions leave the cell, making the inside negative once more. but this time the electrical change starts from the earlier activated end again. Here's something important. Because the direction of electrical recovery, repolarization, is opposite to the original depolarization wave, the polarity flips, so the ECG now shows a deflection in the opposite direction, usually downward. Eventually, the whole fiber is repolarized and the potential difference returns to zero. The cycle is complete, and this entire process is what we see as a wave on the ECG tracing. Now here's the interesting part. What we've been looking at is a one-dimensional view, like left to right or right to left. But what if this electrical activity was happening vertically? Let's take a look at the next diagram to understand that. This diagram shows a cross-section of muscle tissue. As we mentioned before, the direction of the electrical potential difference can be horizontal, vertical, or anywhere in between on this plane. Once again, we're going to use our device to measure the potential difference. We place two electrodes like this on opposite sides. Now imagine the electrical vector points from the more negative area to the more positive one. But this time, unlike the previous example, the vector isn't aligned with the electrodes. So how do we figure out what the ECG will show? Here's the trick. We break the main vector down into two components, one horizontal and one vertical. Now the horizontal component is aligned with our electrodes. Since it goes from the negative electrode to the positive one, the machine will detect a positive deflection. But what about the vertical component? Unfortunately, it doesn't produce a visible signal on this setup. Why not? Let's take a look. In this new diagram, all the cells are at rest. So obviously, there's no potential difference, and the ECG shows zero. Then suddenly, the lower part of the tissue begins to depolarize, and that area becomes negative. So now we have a vertical vector pointing upward, but both electrodes are placed in the upper region, where the charge is still positive. Since there's no potential difference between the electrodes, the ECG still shows zero, even though part of the tissue is already active. As depolarization continues and spreads further, you might think the reading will change. But again, it doesn't, because both electrodes remain in an area with the same charge. Still no difference. Still a flat line. So what can we do? Let's go back to our earlier example, where we had a diagonal vector that we split into horizontal and vertical parts. We saw that only the horizontal part was detected, because that's where the electrodes were placed. But if we also want to measure the vertical component, we need to place another pair of electrodes along the vertical axis. Now we can measure the vertical potential difference too. With this setup, any vector within this plane can be broken down and detected accurately. For example, if we have a diagonal vector like this, we can now measure both parts. To make this even easier, we can also just place two electrodes directly at the ends of the vector and connect them to a separate device. That way, we capture the full signal as it is. And that's exactly how it works with the heart. But instead of using just 3 leads, we use 12 different leads to make sure we don't miss anything. Each lead sees the heart from a different angle, helping us get a complete and detailed picture. Now that we've covered the basics, let's take a closer look at what's really happening inside the heart. This image shows a cross-sectional view of the heart. At the beginning, all cardiac cells are at rest, meaning their outer surface carries a positive charge. To keep things simple, we're only showing part of the heart so the diagram doesn't get too crowded. In this video, we'll observe the heart's electrical activity using a single lead. So we place 2 electrodes on either side of this lead. To better visualize the electrical changes, we also add the heart's conduction system to the diagram. At first, since the entire heart is at rest and positively charged on the outside, there's no difference in the potential, so the ECG machine shows 0. Then, suddenly, the SA node depolarizes and the area around it becomes negative. This change creates a small electrical vector in the atria. When we compare this vector to the direction of our lead, we see that it's aligned, so the machine records a positive deflection, which appears as a small upward wave on the ECG. Next, the rest of the atria depolarize. Since both sides of the atria become equally negative, the potential difference disappears and the ECG returns to the baseline. This small wave we just saw is called the P wave. Because the atria have relatively thin muscle walls and fewer cells, the P wave is usually small. During this time, the atrial walls contract to push blood into the ventricles. The electrical signal then reaches the AV node and travels down into the interventricular septum. Due to the tissue structure, the left side of the septum depolarizes first, while the right side remains at rest. This creates a small electrical vector from left to right. Since this vector is opposite to our lead direction, the machine records a small negative deflection. This is the Q wave. But because the difference is very small, the Q wave might not always be visible on every ECG. Shortly after, the right side of the septum also depolarizes, and the difference in potential disappears. At this point, the septum contracts. Then, the signal spreads through the rest of the ventricles, and the cells begin to depolarize one by one. Here's an important point. The interventricular cells, endocardium, depolarize before the outer ones. This creates a new vector, which is aligned with our lead. The sum of all these vectors creates a strong overall vector in the direction of the lead, so the machine records a large positive deflection. This is the R wave. Since the ventricles have much thicker muscle walls than the atria, the R wave is much stronger and taller than the P wave. As depolarization continues, the outer walls of the ventricles are also activated, and the potential difference fades again. This whole process results in ventricular contraction, which pushes most of the blood out of the heart. Finally, the last part of the ventricles depolarizes. Because this vector is in the opposite direction of the lead, the machine records another small negative deflection, known as the S wave. At this point, the remaining ventricular cells contract and eject the last bit of blood. So far, we've only talked about depolarization. But as you might expect, the heart can't stay contracted forever. It needs to rest. That's when repolarization begins. Repolarization starts from the same area where depolarization started. Positive ions move back outside the cells, making the outer surface positive again. This creates a vector in the opposite direction of depolarization. And since it's opposite to the lead direction, the ECG shows a negative deflection. Then the rest of the atrial cells repolarize, and the potential difference returns to zero. This is called atrial repolarization. But why don't we see it on the ECG? Because it happens at the same time as the QRS complex, and since the QRS is so much stronger, the atrial repolarization wave is basically hidden under it. Eventually, the atria fully relax and return to rest. Now it's the ventricle's turn. You might expect repolarization to start in the septum, just like depolarization did, but that's not the case. Due to higher pressure on the endocardial cells, repolarization is delayed in that area. So repolarization begins from the outer regions of the ventricles and moves inward. This creates a new vector, but this time it's in the same direction as the lead, so the ECG machine records a positive wave, called the T wave. With the appearance of the T wave, the ventricles relax, and the heart prepares for the next cycle. Now that we understand the mechanism, let's finally answer the question, what's the difference between the types of limb leads? Let's talk about the limb leads, and we'll start with the standard leads, which include lead 1, lead 2, and lead 3. As you've probably noticed from the previous explanations, electrodes and leads are two different things. An electrode is the actual sensor placed on the surface of the skin to pick up electrical signals. A lead, on the other hand, is the difference in electrical potential between two electrodes, and that's what gets recorded on the ECG. One important point, a lead always has a direction, from the negative electrode to the positive electrode. To record the limb leads, we need 4 electrodes placed on the limbs. These are labeled as RA, right arm, LA, left arm, RL, right leg, and LL, left leg. Out of these 4, only RA, LA, and LL are involved in actually recording the ECG signals. The RL electrode is just used for grounding. It doesn't contribute to the leads themselves, but it helps reduce noise and makes the ECG recording cleaner. Now, by connecting these electrodes, we can measure the differences in voltage between them. Lead I is the potential difference between LA and RA. RA is negative, LA is positive, so the electrical vector points from the right arm to the left arm. Lead 2 is the difference between LL and RA. Again, RA is negative and LL is positive, so this lead points from the right arm to the left leg. Lead 3 is the difference between LL and LA. This time, LA is the negative electrode and LL is positive, so the vector points from the left arm to the left leg. These three leads together form a triangle known as Einthoven's triangle, something we'll talk more about in the next section. Now it's time to talk about the second group of limb leads, which are the augmented leads. These include AVR, AVL, and AVF. I'll go through each of them one by one, but before that, let's understand what makes this group different from the standard limb leads we discussed earlier. Leads are generally classified into two types, bipolar and unipolar. So what do these terms mean? Bipolar leads are the simpler type. They involve two active electrodes, and the ECG machine measures the potential difference between them. That's exactly what happens in the standard limb leads, like lead W, 2, and 3, where we're comparing signals between two limbs. But unipolar leads are a bit different. Here, there is only one active electrode, and the machine compares it to a reference point, which isn't a real electrode, but a calculated average of other electrodes, a kind of virtual reference. Examples of unipolar leads include the augmented limb leads and the precordial leads. Let me explain this more clearly with a diagram. Just like before, we place the limb electrodes in the same standard positions, RA, LA, RL, and LL. Now let's say we choose RA as our active electrode. Instead of comparing it to another physical electrode like LA or LL, the machine compares it to a virtual line, which is the average of the signals from LA and LL. This gives us lead AVR. Similarly, in lead AVL, the LA electrode is the active one, and it's compared to the average of RA and LL. And finally, lead AVF uses the LL electrode as the active one and compares it to the average of RA and LA. So to sum it up, all three augmented leads are unipolar. Each one uses a single active electrode and compares it to the average of the other two limb electrodes. And if we put all the limb leads, both the standard and augmented ones, on a diagram, we get a full picture of how these leads look spatially, which helps us understand the heart's electrical activity from different angles. This diagram is really important, and yes, you absolutely need to memorize it. But don't worry, if you already understand how each lead is positioned, memorizing the whole layout becomes pretty simple. Let's start with the standard limb leads. Lead I runs horizontally from the right arm to the left arm. Lead 2 goes from the right arm to the left leg, diagonally downward. We'll skip the vertical lead for now. I'll get back to that in a second. Lead 3 goes from the left arm to the left leg. So that's leads 1, 2, and 3. They form the basic triangle we already talked about. Now let's add the augmented leads. The lead that lies between lead 2 and lead 3, pointing straight downward, is AVF. It's vertical and goes directly toward the feet. That's it for the lower half of the circle. Nothing else down there. Now let's look at the upper half of the circle. It's actually pretty easy. The lead pointing just above lead 1 is AVL. The last one is AVR, which is directly opposite to AVL, pointing up and to the right. It's a mirror image of AVL across the center. So far, so good. Now let's talk angles, because you do need to memorize a few of them. Each of these radial lines is separated by 30 degrees. Here's how that works. Lead I is at 0 degrees. AVL is at negative 30 degrees. Lead 2 is at plus 60 degrees. AVF is pointing straight down, so it's at plus 90 degrees. Lead 3 is at 120 degrees. And finally, AVR is at minus 150 degrees, which is directly opposite lead 2. Since AVR and AVL are both 30 degrees away from lead 1, and they're mirror images of each other, they form the same angle, just in opposite directions. Once you understand this, the hexaxial diagram becomes much easier to remember, and it'll help you a lot later when we start analyzing the heart's electrical axis. Now let's move on to the precordial leads. We've already talked about the placement of these leads on the chest, and we know exactly where each electrode goes. But what about their second electrode? If you remember, precordial leads are unipolar. That means there's only one active electrode, and the ECG machine calculates the potential difference between that electrode and a virtual reference point. So where is this reference point? Remember Einthoven's triangle, the triangle formed by the standard limb leads. The center of that triangle is called Wilson's central terminal, and this is the virtual reference for all the precordial leads. To understand this better, imagine we're looking at a transverse cross-section of the chest, right at the level where the precordial electrodes are placed. Now look at this image. The central point you see here is Wilson's terminal. Each precordial lead, from V1 to V6, records electrical activity from its own position on the chest, directed toward Wilson's terminal. In other words, each lead looks at the heart from a different horizontal angle and records how the electrical potentials change in that specific direction. This gives us a comprehensive view of the heart's electrical activity across the transverse horizontal plane. Now you might be wondering, why do we need to know all these leads? Why not just focus on one or two? Well, the answer is simple. The heart is a three-dimensional organ, and you can't fully understand what's going on inside it by looking from only one angle. Think of an ECG as a security camera system, and each lead is like a camera looking at the heart from a different viewpoint. If you only have one camera, you'll miss a lot of what's happening in the room. But if you have multiple cameras, or in this case, multiple leads, you get a complete view of the entire heart. So let's break it down visually and simply. Which part of the heart does each lead observe? Lateral wall. Leads I, AVL, V5, and V6 look at the lateral side of the heart. So if something abnormal happens in the lateral wall, these leads are where you'll see the changes. Anterior wall. Leads V1 to V4 observe the anterior surface of the heart. But they're not all identical. V3 and V4 focus more on the anterior wall of the left ventricle. V1 and V2 focus more on the interventricular septum. Inferior wall leads 2, 3, and AVF look upward from below and reflect activity in the inferior wall of the heart. And finally, we have lead AVR, which provides a unique view of the medial aspect of the heart, or more specifically, it closely monitors the right ventricle. Important note, these leads don't have sharp borders like country maps. There's a lot of overlap between the views of neighboring leads. For example, V1 is placed closer to the right side of the chest, so it can pick up signals from the right ventricle as well. There are also situations where we need to view the posterior back wall of the heart. In such cases, we can place additional electrodes as V7 to V9, but that's less commonly done. Now that we know which leads observe which parts of the heart, it becomes much easier to pinpoint where the problem is based on ECG changes. One of the most common heart issues is ischemia, a reduced blood supply to part of the heart muscle. This often happens due to blockage in one of the coronary arteries. So let's go one step further and ask, if there's damage in a specific part of the heart, which coronary artery is most likely involved? Let's briefly review the main coronary arteries. The aorta, just above the aortic valve, gives rise to two main coronary arteries. 1. Right coronary artery, RCA. 2. Left coronary artery, LCA, which quickly branches into the left circumflex artery, LCX. The left anterior descending artery, LAD. The LCX supplies the lateral wall of the left ventricle. So if the LCX is affected, you'll likely see changes in leads I, AVL, V5, and V6. The LAD runs down the anterior surface of the heart, supplying the interventricular septum and anterior wall. So, issues with the LAD show up in leads V1 through V4. The RCA supplies everything else, the right ventricle, the inferior wall, and the posterior wall of the heart. So changes in leads 2, 3, and AVF, or sometimes in V1, indirectly, may indicate RCA involvement. To keep it simple, if you remember the left coronary artery, LAD and LCX, and their associated leads, then all the other changes typically point to the RCA. Thank you for watching. If this video helped you, please like it and share it with your friends. Don't forget to subscribe and turn on the bell so you don't miss new videos. Take care, and see you in the next video.